Yes, sir, we are live.
Okay. Good evening, everyone. I welcome everyone for this second IAS Academy Corner meeting. And today we are having excellent talks. One is by Dr. Arumugam from Ramchandra Medical College. He is the master of bone Bone graft. So he is going to talk A to Z about PTP graft. And we have other two interesting cases by Dr. Ramakanth Rajagopalakrishnan and Dr. Srinivas. And at the same time, I like to thank Dr. Gopinathan from Calicut and Dr. Vikram Sharma from Jaipur for agreeing and going to coordinate this meeting. With this, I hand over to Gopinath to introduce the first speaker and start the meeting.
Thank you for giving me this opportunity, Dr. Sundararajan and IAS. I know that Dr. Arumugam needs no introduction to this audience. He's a professor and head of the Department of Sports Medicine at SRMC, Chennai. He's a master of bone-tendon-bone grafts, as Sundararajan already told, and he has different techniques of how to harvest the bone-tendon graft. So I take this opportunity to invite Dr. Arumugam, and we will learn a lot from him, I'm sure. Please continue, Dr. Arumugam.
Okay. Very good evening to all of you. Let me share my screen. Okay. Is my presentation visible?
Yes, yes.
Okay. At the outset, I like to thank the Indian Arthroscopy Society for giving me this opportunity. And the topic of my talk is BTB version 2, a versatile graft option for ACL reconstruction. The humankind goes through constant evolution and innovation, as you all know. And if I show you this picture, many of us won't even recognize this is the version 1 of the most popular Apple or MacBook what we have now. Similarly, many things goes through evolution. Even pandemic, we had version 1 and just recovering from version 2 and preparing for version 3. When we talk about BTB graft, what we have in mind, what comes to mind is this is the BTB version 1, where we have a long incision about 10 centimeter or so in the middle of the midline, and there is a graft what we used to harvest, and all the negative factors or disadvantages described in the literature is all associated with BTB version 1. What I'm going to talk about is BTB version 2, where the incision is different, as well as the graft also we have modified, and this we're going to talk about more in detail in coming slides. The experience with the BTB is quite bizarre. So we interviewed almost about more than 100 delegates, young arthroscopic surgeons who came to our IAS bioskill lab at Ramachandra, and they all have minimum of 3 years of experience in arthroscopy. Hardly 5% have ever seen a BTB graft harvested for ACL reconstruction. But all of them, 100% of them unequivocally said it causes anti-knee pain. So it's all because of the literature and from the theory. And maybe because of the industry push. The implant, what we need to use the fix the BTB graft is not that expensive. Even to train these surgeons in the cadaver lab, it's difficult because we don't get the necessary instruments, oscillating saw, which is very important for good harvest of the graft. We don't get it for any of the cadaver lab. Even international labs we've been to, we don't find them. So actually it's bad for the patient we treat. We ignored the gold standard graft, which is the BTB graft. But all these surgeons, they said they go for BTB graft when they treat high-end athlete or for revisions. So if that is the case, why don't you think of a BTB graft as a primary graft at least for all your patients? Why we prefer BTB graft? The sufficient strength and the ribbon-like structure similar to the native ACL as described by Sibold, and excellent integration of a bone plug into the socket as early as 8 weeks makes the BTB most preferred graft. And this is a review of comparison of BTB in hamstring, the various literature. It came out 5 years ago. BTB scored over hamstring in all the points, like strong graft. Poor graft quality is more with hamstring. More often, especially in Indian population, the width of the graft is less than 8 millimeter, which is optimum width. Then we go for doubling, and 5 grams, and different technique to augment. And the graft fixation, the bone-to-bone healing, cost is less. Various studies have shown the stability is better, and the stretch is none, no tunnel widening, revision is easier. So, and also, more importantly, the graft biomechanics. If you compare with the ACL, all the 3 popular grafts are, if not better, equal to the ACL graft, native ACL tendon. But the most important, the outcome return to sport, only BTB can say the early to return to sport is ACL is 4 months. Even though we recommend the athlete can go back only as early as 8 or 9 months after the ACL reconstruction, there are in the instances the career-defining moment where the athlete has to continue his career, the sport, otherwise his career will end. So he is willing to take all the risk, he'll give all the consent, and you have to give the best graft possible to have a less failure. Then you go to only BTB, and we are done in our centers. Professional football athletes know the choice, but we can't even think of that doing with the other graft. So if you talk about this game of graft as a surgeon, which is better, which is important, the graft is bad or the surgical technique. Of course, the surgical technique, especially BTB harvest, is more like an art. You have to have a perfect bone plex, tibial bone plex extension to minimize the graft tunnel length mismatch is important, and preserving the alpha fat to avoid a fluid leakage, and the stress-free plug resection to avoid donor site fracture, which is the fracture always happens intraoperatively, never happens postoperatively. So it's all good equipments. And other important thing is how you can BTB graft can be templated. All you need is a same MRI. You can have a precise pre-op graft measurement. You can measure the patella tendon width, tibial tunnel insertion, and the patella morphology, and as well as your tibial tongue. You can visualize it and see how deep you have to go down, because the insertion of the tendon is not here for the younger colleagues. The insertion of the tibial, the patella tendon is way here. So if you don't harvest this part of the tibia, then the tibial, when the patella tendon is more long, then we end up in the graft tunnel length mismatch. And we presented this in the IAS Con Calicut. In fact, it's selected for the final medal paper. 100 knee MRI and the morphometry of the patella tendon. What we presented was it is a BTB graft is a predictable graft option for ACL reconstruction. So you don't have to have a surprises. Patella all down. Those things can be very well assessed beforehand, and accordingly you can adjust your technique. So traditional incision, when you talk about the BTB, all BTB version 1, this is the incision what we used to do, 10 to 15 centimeter of midline incision, because their knee is fixed position. Whereas in BTB version 2, we do a mobile window technique. I'm going to this video. Knee has to be in about 3rd degree knee flexion to start with, the cavalier incision. Then you made a mobile window, and the further incision is on the midline. So the skin incision not on the midline. Further than that, all in midline. You have to separate the peritoneum, and you have to preserve it, and you have to repair it at the end, and other to reduce the donor side mobility. So mobile window is what we need to do. Like this. You can move over the tibia and the patella. Then make 130 degree of knee flexion, so tendon isn't tight, where you make the incision on the tendon. Otherwise, you'll have a mismatch of the graft fibers and the bone plug. Once you do that, again extension, make the tibial bone plug normally about 25 to 30 millimeter. Always pre-drill it before harvesting the bone plug out. Use the small saw. What you use in the plastic surgeons, not a big knee saw. Never use the just osteotome and mallet. Osteotome mallet only to deliver the bone plug. Once you do that, that's the tibial tongue. And knee is put into full extension. The mobile window is placed over the patella. Again, pre-drill on the patella bone plug and use a saw. Never use 90-degree of angle. Harvest the patella apex first, and so that it reduces the stress sizes. And this is at the end of the incision, small one. And this is the tibial bone plug that reduces the effective tendon length. What we need to understand is this is how the saphenous nerve branch coming from medial to the midline. So if you have the incision on the midline, definitely you're going to have more donor side morbidity and numbness or so, and various technique to avoid that. A good friend Philip Andrew already demonstrated in IAS meetings, like he uses 2 incision technique so that avoid the saphenous nerve. We started with the curvilinear, now move over to the small paramedian, and the skin incision subcutaneous here, then the mobile window is moved over here to harvest the patellar tendon. So another big myth is the anti-knee pain as only with the PTP. We published this in Journal of Orthopedics last year, 2020, and 2019 presented this in ISACOS, about 1,200 patients, 600 each. The BTP harvest is the version 2, mobile window technique, and hamstring is the same traditional method, and there is no major difference in the anti-knee pain. Both the hamstring and the BTP had a similar rate of anti-knee pain as in the other literature. Other, again, myth is the transtibial is a non-anatomical. The evolution of the ACL reconstruction, you all know, we started the ACL reconstruction with the transtibial technique. Then the transportal became only when the double bundle concept became popularized by Freddie Fu. When we started initially the conventional transtibial technique, we aimed for 1 o'clock or 11 o'clock, and we all know now we don't follow that clock version anymore. And we can optimize the transtibial technique anatomical by what we follow differential tunnel. The tibial tunnel of the is larger than the femoral tunnel. I'll explain to that. And we have to optimize the graft and then the femoral tunnel positions and the tibial tunnel entry point. The graft optimization we talked in detail. More pitfalls and steps are explained in our chapter published in the textbook. Mainly, this is the tibial tongue what we need. We standardize the bone plug for the patella 9 to 10 millimeter, whereas the tibia 10 to 11 millimeter. Then we point the femoral tunnel before drilling the tibial tunnel. And as explained by Stephen Howell, it's the equidistance at the footprint. It's a 12 o'clock, it is the low here. This is where the PL bundle, here is the AM bundle. So midpoint what we take is. So this is the microfracture all comes through the middle portal. This is the point we need to get it. And we try to reach it through transtibially. If we don't get it, we don't compromise. We drill this through the middle portal. But the transtibial technique is more like a marriage. If you have the wrong, the tibial tunnel entry point, your femoral tunnel will be at the wrong point. When we started about 20 years ago, tibial tunnel entry point was close to the tibial tuberosity. As now described by Chabra, the tibial tunnel entry point is midway between the tibial tunnel tuberosity, middle border of tibia. So near almost close to the MCL. This is a good trajectory for not only getting the anatomical femoral tunnel, also for easy passage of the graft. Arthroscopic picture, and you can see this is the entire middle surface of the femoral tunnel, and this is where we need to get in. Not there, that's the 11 o'clock position. So tibial tunnel is reamed, the guide wire is placed, then serial reaming to 11 millimeter. That gives the tunnel widening width enough for the femoral guide to be rotated and placed not anteriorly, inferiorly and down. And this is the point where we made through the middle portal that we can reach. Then you ream through it 25 millimeter, normally you do that, and your posterior wall will be there. Always use the offset and the femoral tunnel, in middle portal view. You can see how nicely it's anatomically placed. Then pass the graft, the bone plug anteriorly. Here the notch is made where the guide wire is placed. The knee is flexed above 130 degree to make the alignment parallel. We use a metal screw. And these are the end of the fixation here. And here the tibial tunnel entirely filled with the bone plug. And with the view through the middle portal. So the transtibial, another myth busted is the transtibial is non-anatomical. So we use this technique. This paper published about 2016 by Korean study. They compared transtibial and transportal 20 each, and they didn't find any difference. How they made the transtibial is once you make the tibial tunnel, they make the tibia internal rotate, and also they make a varus so that they get this low point, and they can use the femoral guide inferior and down, not facing anteriorly, that go into the total clock position. And the double bundle ACL reconstruction, another myth was we can't use the BTB graft. Of course, double bundle ACL reconstruction is gone out of favor. Hardly very few people do that. But even then, if you really want to do, the BTB version 2 is more versatile. You can do even this paper published almost 10 years ago. It's possible, but I don't know believer of double bundle, so I haven't done that. So now in version 2, the indication is almost all my patients, I see whether I can do a BTB ACL reconstructions. All skeletally matured individual, and high performance athlete, both male and female, and also heavy workers. Contraindication is ACL insufficiency in adolescent. When skeletally immature, the face is open, then it should not be done. And the patellar tendinitis, when the fibrous tendon, which you can pick up with the MRI, then we don't do it. Even the anterior knee pain, chondromalacia patella is not a contraindication anymore in the younger patients. And other myth is you can't do a partial ACL reconstruction, you can't preserve the remnant. This is an athlete, we have almost most of the AM is gone and the PL is gone, and most of the tibial remnant is placed. So we use the BTB graft, but here we use 9 millimeter for the patella, 10 for the tibia. So we ream the tibial tunnel as we normally do, then preserve the tibial remnant as possible. And then we made the femoral tunnel and the anatomical point. Recently, we started using the flexible reamer. That gives the bone plug going in and fixing it. And this is at the end where we're able to preserve most of the remnant and the new graft is placed. Here we use the bio screw to fix it. And the revision ACL reconstruction could be single stage with the BTB graft. The patient who had a kabaddi player, 40 years old, had 10 years before hamstring, had a road traffic accident. He had almost about 12 to 30 millimeter of tibial tunnel. So if you're not for BTB, you have to go for a one stage filling and then do the hamstring with the BTB graft, the 12 millimeter of tibial bone plug. We're able to reconstruct the single stage. In conclusion, many myths are there. The time to be clear the air. The 20 years of experience, no cry and anti-knee pain with the hamstring with the BTB graft. And the transtibial technique can be anatomical if you take good care. And the BTB graft, the problem is the surgical technique. The graft is not the problem. And the BTB graft is not only the gold standard, but also the versatile graft.
Fortis, Amit sportsman or one other.
Yeah.
Thank you, Dr. Arumugam, for the nice presentation.
Thank you.
And the topic is now open for discussion. I request Dr. Vikram, please start discussions by asking questions.
Thanks, Dr. Arumugam. This was indeed a very eye-opener topic. And indeed, when we have started our arthroscopic career somewhere mid-90s, So we started with bone, patella bone, then gradually we shifted to hamstring due to so many reasons. And you have beautifully elaborated about the using of MRI pre-operatively. We have never been doing that. And how to avoid stress fracture. So the tip was always to pre-drill. So my question to you is that what size of screw you use on the femoral side? Is it the same size or one size less, or what exactly is that?
We use about one size less for the metal screw. And the bio also will be one size less than the actual graft. If it is 10 millimeter of the femoral tunnel, we use 8 or 9.
Okay, so you use bio screws also.
Bio screws also, yeah.
And in this case, you have gone with.
We have to tap it. You have to pre-tap it. Otherwise, you may break the bio screw, and the angle has to be under the reflection. Otherwise, you may break the bio screw.
And is there any tip when we insert our screw, there is a rotation of graft sometimes on the femoral side?
Yeah.
So graft start rotating whenever we try to tighten that. So is there any tip for that?
The main thing is the guide wire may rotate. That's why you make a tunnel notcher. So the guide wire is placed there. Then you always have to kind of pull the graft down. When you're fixing in the femoral tunnel, the tibial tunnel graft has to be pulled down. Thereby, you can avoid the graft twisting when you screw it. There are some sheath on the screw which will prevent that. I used to do it earlier on, but now I don't use it. Without that, I will fix it.
And I have my last query, that you have used a transtibial technique.
Yes.
So is there any possibility that we can do BTB with transportal also?
Yeah, absolutely. You can do it with the transportal also. But as I said, if I always locate the femoral tunnel anatomical point. So if I don't get it, the tibial tunnel entry point somehow is not correct, then I don't compromise. So you do the medial portal. The only problem is that you have to make the bone plug should not be 25 millimeter on the patella. You should be less than 20, maybe 18 or 19, because you have to flip the graft. Because you have the middle portal, drill the femoral tunnel middle portally, and the tibial tunnel. In a hamstring, you pass the graft from tibia into the bone easily because of graft. The bone plug passing the difficult, so that bone plug is small. But that's why I don't prefer middle portal, because the bone plug of this small. So a longer bone plug is better. You can use with the middle portal also.
Yeah, I agree. I do through the middle portal technique only whenever I do a bone petalatan graft, as Arumugam sir said, and I agree with that, because we cannot take more length of the bone in the femoral side, because we cannot leave it out and take it inside the tunnel, because we need a 90 degrees angle to take it inside.
It will be difficult.
Yeah, so I usually take around, say, as you said, like a 17 or 18 mm only in the patellar side.
Patellar side, correct.
Okay. And so one more thing, do you keep this patellar plug on the femoral side or on the tibial side?
Yeah, I always keep the patella for the femur, tibia for tibia.
Okay, great. Yeah.
Aru sir, I have two questions.
Yes.
Dr. Chirag here.
Yes, Chirag, I see you.
Intraoperatively, if you find a length mismatch of your patellar tendon, if you find that your patellar tendon harvest is longer than what you desire, what would you do? How would you bail out? That's one question.
Yeah.
Second is, on the femoral side fixation, do you see any advantage of outside in fixation than inside out in terms of the graft turning? What was Dr. Vikram was talking about, the graft being turned at the end of inside out screw placement. Do you have an advantage for placing the screw outside in?
Yeah, very good questions, Chirag. Number one, coming to the tibial tunnel mismatch, one of the common problem they cite. That's what I told you. The very important how to prevent is to harvest the tibial tongue. If you have a tibial tongue, you don't have the problem. but somehow you're not able to harvest the tibial tongue, then you can advance the femoral bone plug into the patella a little more, because then a little bit tendon will be there. You can use a bio screw, or you can flip the bone plug on the tendon, thereby reducing the tunnel length. And one more technique is to once you fix the femoral bone plug, you can rotate the graft, thereby shortening it, and tendon length will be shortened. Then you can fix on the tibial tendon. But this all can be overcome if you take extra care on the morphometric, the pre-MRI morphometric, and then harvest the tibial tongue. Then you don't have this problem.
Yeah, there are two questions from the delegates.
Question, sorry, from the outside in, I have not used it because another external one more incision, so I never done that. But sounds a good idea. I know some surgeons do that. It is also a viable option.
Dr. Arumugam, two questions from the delegates.
Yes.
Any experience of graft rupture at bone-tendon interface and how to tackle the situation?
Yeah, as I said, all this complication of patellar fracture, tendon rupture, all surgical technique. The steps and tips what I mentioned, if you take care, it will never happen. To be honest, in my 20 years experience, I never had that, because when can that happen? When you make the incision on the tendon, when tendon is not in tension. In a full extension, tendon is lax. If you make incision, you don't have a proper cut on the fiber and bone. That's why you make 130 degree of knee flexion. And then other reason, when the bone plug and cut off is, you put the drill hole for passing the wire after harvesting the bone plug. Then there may be the chance of do that. So we do that. We don't do that. We do it pre-drill before it. In the worst case, if you have it, then what you can call piggyback, that bone plug can be placed on the tendon and the sutures are tied over it, you can still use it.
One more question from Sujit Jose. He is asking, why are you favoring transtibial femoral drilling? Because someone has to hold the leg in internal rotation and varus. Why not transportal, which is much easily reproducible?
Yeah, see, holding the transtibial and varus, not technique what we follow. We follow standard leg break, 90 degree of flexion only. So do that. The reason why I use transtibial, as Dr. Sundararajan mentioned, the transportal, the bone plug has to be only 18 or 19. So I personally feel, why should you compromise on that? All our studies have shown you must have at least 25 millimeter of bone plug in the femur with a good fixation. So that's the reason why I want to do the transtibially. And if I can get the anatomical tunnel and the footprint of the femur, why not using transtibially?
Any other questions from the EC members?
Dr. Arumugam, can you predict the healing? What's the difference in healing in bone-tendon-bone graft and hamstring graft? What's the difference in healing?
Well, all the studies have shown the healing is much better with the BTB, because we all know orthopedic surgeons, the bone-to-bone healing is far superior than the ligament to the bone healing.
The mechanism of healing, is there any aperture healing here or only bone union? Or there is only aperture healing in hamstring? What's the mechanism of healing?
Yeah, the aperture healing, it has both bone healing as well as aperture healing with the BTB. Whereas in the hamstring is only sharp fibers and aperture healing. That's why the BTB healing is better.
So there is a double healing here.
Double healing. That's why we can theoretically, or we can let your athlete go back to the sports much earlier. The studies have shown as early as 4 months, which you can never do with the tendon, either is hamstring or quadriceps. Without the bone-to-bone healing, you can never allow that.
Do you also think that vascularization is better with bone-tendon-bone, or vascularization is less with hamstring? Is there any difference in vascularization? Because that is a final thing which is very important.
I think vascularization, both are different. One is tendon, another is ligament. And it has come with the bone plug at the both end. So that may be another reason why the healing is better with the BTB graft. It is more vascular.
You think this will get more vascularized easily than hamstring?
With all the evidences, the literature shows, I mean, it is that may be one of the reasons why healing is better with the BTB graft.
Dr. Sundararajan, what's your opinion about vascularization of these two different grafts?
Really, I mean, the only the fixation is just different between the hamstring and the PTB. So the healing, what we are talking about, only in the femoral tunnel and the tibial tunnel. Really, I'm not sure about the vascularization of the graft. Is there any difference between the hamstring or PTB? Really, I'm not sure.
And chance of tunnel widening? Tunnel widening,
absolutely more in the hamstring. All of us aware of that, but we know that it clinically doesn't make any difference in the outcome. And even in the long term, we don't. We only it's a radiological finding which most of the literatures are quoted. But clinically, I don't think it is going to affect the functional outcome of in the both the groups.
now we teach our students that femoral tunnel should be horizontal, parallel to the upper tibial plateau. So in a transtibial technique, we will never be able to do that. So is there any point in making the tunnel in the femur parallel to the tibial plateau? Or is there any difference? What's your opinion?
Sir, I'll ask a question. Can you repeat the question? Sorry, Gopi again.
Now, he said that when you do a medial portal technique, we go more horizontal channel. When you do a transtibial, it is more vertical.
Yeah, but I think, as I explained to you, the transtibial more vertical as a older conventional, where you're aiming 10 o'clock or 1 o'clock. We don't do that anymore. We aim the low portal, I mean low footprint, low tunnel. So even with the transtibial, we're going more parallel to the tibial plateau only. Otherwise, you won't be anatomical. So how to do that only technique? We do differential tunnel with, so that we can rotate our femoral guide down and inferior to get more lower, which is more parallel to the tibial plateau. Rather, the Korean studies have shown where they hold the leg in the varus and the interrotation. The whole point is how to make the transtibial parallel to the tibial plateau. Then only become anatomical. If you can't do that, it won't be anatomical.
Is it easy to make the tibial femoral tunnel parallel to the ground, or parallel to the upper tibial plateau in transtibial technique? Is it very easy?
No, it is, I wouldn't say easy. It can be done if you take extra care. Of course, medial portal, it's very easy to do that, right? And whereas the middle portal, I find I have to compromise on the bone plug length. So why should do that? I'll go for the transtibial if I can get it same anatomical footprint transtibials.
Dr. Sundararajan, what's your experience? How can you make it parallel to the upper tibial plateau in a transtibial technique? How do you do that? What's a real technique on making it, or is it impossible?
Really, I'm not sure, because I do through the medial portal technique for a long time. But probably I don't know, because Dr. Arumugam is using the flexible reamers, so it is possible they can change the direction. But I don't have experience of doing transtibial technique. I was doing transtibial technique from 2004, and all of us know that once we started doing medial portal technique for hamstring, and we could found out that PTB graft also can be done through the medial portal technique if we can shorten the femoral patella graft to the femoral side. So that's what we discussed before. If we get 18 or 19 mm of patella tendon bone for the femoral side, it is always easy to do a anatomic reconstruction through the medial portal technique. So I don't have experience of doing transtibial technique, and getting the horizontal really is a bit tough. I think Dr. Arumugam also agreed for that. It's not possible to get the horizontal to, parallel to the tibial plateau is difficult through the transtibial technique.
Gopi sir.
Yeah.
Gopi sir, Dr. Chirag here.
Yeah.
Sir,
Nice to meet you. Nice to meet you.
Sir, until our entry point to the femoral side is precise, if the site of insertion is precise, does it really make a difference if the tunnel is horizontal or vertical?
No, with the entry point, you can make both horizontal and vertical tunnels.
If the entry point is right, will it make a difference with the tunnel if it's horizontal or vertical, if your entry point is right?
Yeah, that's
how does it make a difference?
That's what you don't really need a horizontal tunnel. As long as your entry point, the footprint is in the footprint. You don't need it. And I do hamstring, and then I use the middle portal technique. I don't use the transtibial for the hamstring.
So I think we agree that now, I mean, PTP can be done through both transtibial and also through the middle portal technique. I think all had given a good results in the literature wise too. So, and Dr. Arumugam showed that it's not difficult to make an anatomical tunnel through the transtibial technique. So there's the difference is the healing, because bone-to-bone healing. So the entry point of healing is very important than the orientation of the tunnel. I think that is more important. So because of the time constraint, can we finish this discussion with this? And can we?
I think there is one more question. I think Dr. Ramakanth is going to ask it.
Yes.
Okay, Ramakanth and Ranajit, only two.
Doctor.
Yes, Ramakanth.
Before that, there is one question from the delegates. Does BTB has any proprioception advantage as it does more anatomical healing and more original ACL?
Well, again, a good question, but so far all the questions was BTB has more anti-knee pain. It doesn't have an advantage. So this question doesn't come, but maybe so. Because what he means is intraoperatively, when in the joint intraarticularly, maybe it gives better proprioception. That's why it gives better stability. That's a question, a good point, but there is no evidence to say it is right.
Yes, Ramakanth.
Sir, no, actually, I want to read out that question from the delegate. It was put in the YouTube. That's all, sir.
Ranajit, last question.
Yeah, Dr. Arumugam, sir, excellent presentation.
Hi, thank you.
Do you have any experience of using this PTB graft in skeletally immature individuals, say older age children? Do you have any experience? And if at all you are using in those individuals, what are your tips to use it?
No, the skeletally immature, if face is open, you should never do BTB. It is a problem because then that will have a growth problem. You have to go through only the hamstring. You should not use when the face is open.
Yeah, post-pubescent children, do you ever use BTB graft?
That's why if the physis is fused, then I use BTB. If the physis is open, I will not use BTB.
Okay.
I request Dr. Vikram to introduce next speaker, please.
Yeah. So thanks a lot, Dr. Arumugam. So guys, now we are going to move ahead with the case presentations, and we have two very interesting cases. First would be Dr. Srinivas, and he's going to talk about a very interesting case, that is aplasia of ACL with an unusual meniscus tear and deformities of lower limb. So Dr. Srinivas, this is going to be very interesting. All yours. Please share your screen.
Thank you very much. Can you see the screen?
Yeah, this is very much visible.
Good evening, everybody. I would like to thank the Indian Arthroscopy Society for giving me this opportunity. I would like to present an interesting case of congenital ACL aplasia with a bucket handle tear of the medial meniscus and multiple deformities of the lower limb, along with their management. So congenital aplasia of the ACL is a rare condition with an incidence of 1.7 in 100,000 live births globally. The most common associated conditions are fibular hemimelia, proximal focal femoral deficiency, and congenital dislocation of the knee, but it can occur as an isolated case. The case here is one of mild fibular hemimelia. Fibular hemimelia is a congenital deficiency where part or all of the fibular bone is hypoplastic, dysplastic, or aplastic, associated with hypoplasia, dysplasia of the tibia and parts of the foot. It is a longitudinal deficiency, and its incidence is between 7.4 and 20 per million live births. Part of this case has been published. The relevance of this case to arthroscopic surgeon is due to the intra-articular pathology that is associated with the condition. The patient is a 22-year-old lady who presented with a 1-week history of severe knee pain and difficulty in walking. She had knee pain about 2 years prior to that and was treated conservatively. She also had an acute pain in the knee 1 year before, which was treated conservatively, and she did not complain of instability of the knee at any stage of her life. On examination, there were no systemic problems. She had a valgus deformity of the tibia in the right lower limb. Right knee was lower than the left. Fourth and fifth toes splayed, and right foot was smaller than the left. The foot itself showed splaying the fourth and fifth toes. It was smaller than the left, and the splaying was not correctable. There was no evidence of ankle instability and no neurovascular deficit distally. And on clinical examination, the knee showed Lachman anterior drawer and pivot shift were 2+. PCL, MCL, LCL, PLC, and PMC were intact. She had full flexion of the knee, but painful at extremes. And she had a limb length discrepancy of about 2 centimeters. Radiograph of the knee and the foot showed valgus deformity of the tibia of 5 degrees, a blunt tibial spine, no major hypoplasia of lateral femoral condyle, an absent fifth metatarsal. Fourth metatarsophalangeal joint was shared by the fourth and fifth toes. Proximal phalanx of fourth and fifth toes were fused at the base, and the ankle appeared normal. Limb alignment view showed approximately 4 degrees of valgus in the shaft of tibia. MRI showed evidence of tear of the medial meniscus, an absent ACL, and a double PCL sign, a possible bucket handle tear of the meniscus. So the plan was to take care of her acute pain first with a meniscal repair. Once repaired, it should be protected by a stable knee. So ACL reconstruction and meniscal repair was planned as a first step. Other deformities were planned to be corrected as a second step. For the tibia, Elisaro fixation was planned, and a closing wedge osteotomy and correction of fourth and fifth toe deformities were planned. Examination of the knee under anesthesia showed 2+ Lachman anterior drawer and pivot shift test. So meniscal tear was noted in this. It is a horizontal flap tear of the medial meniscus, which was reduced. The intercondylar notch area itself appears to be covered with cartilage-like tissue with no evidence of ACL footprint on the tibial or the femoral sides. The flap tear was unstable. It's actually, the flap had bucket handle. The femoral side of the flap had bucket handle inside. So the tibial side of the flap appeared to be intact. So meniscal repair was done with a non-absorbable suture with 3 oblique sutures, stabilizing the bucket handle. The free edge of the meniscus was debrided and freshened. ACL reconstruction was done using an all-inside ACL reconstruction technique. The flap tear may have occurred when she had an acute knee pain about a year ago, and the recent injury may have created the bucket handle tear of the femoral side of the flap. I had used stiff suture here because loading onto the meniscal menders here is a bit easy with the stiffer suture. But patients tend to complain of irritation under the skin with these. So I have shifted on to using fiber wire for repairing meniscus. So once the meniscus was stabilized, some trephining was done posterior for the posterior part of the meniscus, and ACL reconstruction was done. So this is the post-operative radiograph. There is evidence of mild dysplasia of the condyles and a blunt tibial spine. She recovered very well and was advised corrections at 3 months for the tibia and the foot. The first part of the case was published, and she was advised to avoid sporting activities until after the second stage. She came back about 5 months after the first procedure for the second stage. A fibular osteotomy was done, and Elizaro fixation with a corticotomy was planned at the central rotation of angulation of tibia, but the osteotomy propagated proximally, so lengthening was delayed. Closing wedge osteotomy of the proximal phalanges were done, deformity corrected and fixed with K wires. This radiograph shows full correction of the deformity, and the tibia is aligned well. Last 1 month, the patient was allowed full weight bearing in the fixator, and then fixator was removed. Alignment was good 4 months after the Elizaro surgery. Joint lines were actually symmetrically aligned after correction on both the sides. Limb length has been corrected. This is 6 months after the correction. Clinical picture 1 year after the first surgery. Cases in the literature are a short fibula, valgus, cruciates, ACL. This plastic.
Did he lose the connection?
I think, yeah, we have lost Dr. Srinivas' connection.
Okay, what we can do, I think he almost finished the case. We can start maybe Ramakanth case and we can have a discussion at then. Is it okay?
Yes, I think so. That is
I think
okay.
by the time he will join back.
So Dr. Gopinath, please introduce next speaker. And
Dr. Ramakanth is a trusted assistant of Dr. Sundararajan, as I learned. Last 2 months back, I met him. He's a very enthusiastic young surgeon, and I'm sure he will be the next Sundararajan. I'm inviting Dr. Ramakanth.
Thank you, sir. Thank you for the kind words.
Hello.
Hello, sir. Can you see my screen?
Yeah.
Can you see my screen?
Yes. Please proceed.
It is visible and audible.
Yes, sir. Good evening to everyone. I thank IAS and Sundar sir for giving me this opportunity to present this case. It is an interesting case of primary ACL repair with suture anchor and internal bracing. So the slides are moving. There's a 30-year-old male patient came with a history of injury to right knee while playing football, and he developed swelling and instability, presented with pain and instability, and on giving away. His clinical examination showed moderate effusion with up to 100 degree of movements. Latchman was positive and anterior drawer was grade 1. Not sure, my slides are not moving.
Touch the screen and move it again. Touch the screen.
Yes. So this is a normal X-ray of this patient, and here we can see that MRI sagittal section. There is a ACL tear from the proximal attachment at the femoral end, where we can see most of other distal fibers were intact and wavy. So the patient was taken up for primary ACL repair, considering his age and acute nature of injury and the type of the tear, that is from the femoral side tear. So here we can see that most of the bundle of the ACL was intact. However, the ACL was completely peeled off from the femoral attachment. Only small amount of remnant was attached to the for the femoral attachment. So the repair was planned for this patient, and multiple stitches were taken with the help of knee scorpion in the anteromedial bundle of the ACL. In the AM bundle, first AM bundle, the multiple stitches were taken with the help of the knee scorpion. And then the bed, the remnant tissue at the bed was debrided for the reattachment and clearing, and the small curettage was done at the bed of the ACL. So the first stitches were taken with the fiber wire in the AM bundle, and then the sutures were loaded into the knotless anchor along with the fiber tape. For we are planning for the internal brace. So the AM bundle knotless suture anchor was taken along with the fiber tape. So this is the bone awl for the insertion of the knotless suture anchor for the AM bundle. And here in this picture, we can see that the first suture along with the fiber tape was inserted at the footprint of the AM bundle. So next, the second sutures were taken in the PL bundle of the ACL for the second knotless suture anchor, and here bone was hard, so tapping was done, and then the sutures along with the knotless suture anchor was inserted at the PL bundle region. So and then the sutures were cut. Here we can see that fiber tape is still intact with the AM bundle suture anchor. So here we can check the stability of the repair after putting both the sutures. So it is good and taut and then originally attached. Then the fiber tape, which is along the AM bundle suture anchor, it was draped over the ACL. It was draped over the ACL, and with the ACL jig, the tunnel was made anterior to the ACL footprint, and then which is shuttled out to the anterior cortex, and then again another knotless suture anchor was inserted. So this is after insertion of the knotless suture anchor anteriorly with the internal brace intact. So this is the stability along with the internal brace. So the range of movement was checked so that there is no tightening of the internal brace. So knee went through full range of movement, and we can see that tension was adequately maintained. So to improve the biology, microfracture was done in the notch so that some bleeding happens, and the pluripotent cells come out, and it helps in the healing. Now going to the literature review, Sharma was the first to classify the ACL tears. It's a very simple classification into 4 types, where type 1 is completely soft tissue peel off from the femoral attachment. Type 2 is 20% of footprint of the femoral attachment is intact. Type 3 is around 30%. Type 4 is almost 50% or mid-substance tear. So Vander also came with classification in 2015. So he also has a similar classification based on the MRI findings. This was a MRI finding classification where 90% from distal to proximal length. So that is 90% distal intact and only 16% proximal. The type 2, type 3 varies according to the percentage of proximal stump left, and type 5 is nothing but bony avulsion. So the ideal indication for the primary repair would be in a young patients in acute injury, and for Sharman type 1 and type 2, and for the good quality of the remnant ACL. The advantage of repair is potential to preserve the native insertion and the proprioception function, so that the joint mechanics can be restored back, and it can decrease the post-traumatic OA. The rationale of using the fiber tape would be the fiber tape provides stability and also could act like a scaffold. So together with the loop suture, it can hold the clots better and help in the healing. When it's combined with the microfracture, it helps ACL healing, and also reinforces as a secondary stabilizer for the repair. So based on the various studies, they have shown that internal bracing is definitely beneficial from this case series, which was published in 2018. And the systemic review also had supported the use of internal brace with increased success rate for the healing. Pertaining to ACL, the evolution of ACL, they have been trying since they have been doing the repair in the olden days, but in the olden days, they were doing it with open arthrotomy and suturing technique and with a cast immobilization, which gave the poorer results. As the technique of ACL reconstruction evolved, the repair was given up. And now the ACL repair are coming back with a proper indication. And Sharman was the first to identify the proximal tears would heal better with the repair. So when you consider repair alone or repair versus augmentation, the results were comparable, and re-rupture rate also was comparable, that is 5 to 15%. So in this MRI study of healing of the ACL repairs, where they had used MRI, sequential MRI at 1 month, 3 months, and 6 months, showed that 90% of the cases showed the normal iso-intense signals in the MRI. So the ACL repair heals well. And when you consider the comparison between repair versus reconstruction, Hugelslag et al. Found no difference in the clinical scores, but the re-rupture rate was higher in the ACL reconstruction group than the repair group. And the overall systematic review for the repair showed that ACL repair survivorship can be anywhere between 60 to 100%, and the proximal repairs tend to heal well, and the re-rupture rate was 23%. The revision for ACL surgery was around 30 to 33%, and the re-operation was about 51%. So the take-home message would be primary repair can be adopted for cautiously selecting proper patients, that is young patient, acute injury, proximal injuries, that is Sharman 1 and 2 type of ACL tears, and when you have good sleeve of ACL tissue and there is no frying due to injury. Thank you very much.
Thank you, Dr. Ramakanth, for the nice case. It's always better to repair if possible, and you should get a patient in the early stages. So if you get an ideal patient, there's always an option. We have only little time left behind for discussion. I request all the panelists, please get involved.
Gopinath,
yeah.
The Srinivas has got 2-3 slides more. Can we finish off the slides?
Okay.
Srinivas, can you share your screen? Do you want to show the last few slides which you have?
Okay, sir. Thank you very much.
Unmute also. Srinivas, unmute.
Yeah, please share.
slide.
He has got some net issues. Maybe you can go for a discussion, Gopinath.
Yeah. So as I told, if you get a patient who comes very early with a proximal rupture or proximal avulsion, repair is always an option. And probably the results, even though comparable, the patient is likely to have more of a proprioceptive function that are early studies showing. So the experience of repair may be less with many of us, but still it is a good option. The paper is open for discussion. I request all the panelists to get involved. Dr. Vikram.
Yeah, so if you have any questions, please ask. Yeah, Ranaji.
Yeah.
Yeah, I have a question.
Yeah, I have.
Just two questions. Yeah. One is, what is the knee flexion? Sorry.
Okay, IPS, carry on.
Okay. So what is the knee flexion angle where you would tie the fiber tape? Which is, I mean, as per literature, what is the best position of the knee flexion? So that it is not too stiff as well and you get flexion as well.
Yes, anywhere between 30 to 50 degree would be the position for you can fix the fiber tape.
Okay.
Like
and
how
the second question is,
after fixing in, we always take it through knee range of movement, so that to see whether any slackening of the fiber tape is there or not. So that also tells that whether we can feel the movement of the knee, or whether it is too tight or any slackening in the fiber tape.
Okay. And the second is, I mean, the technique which you showed is essentially an technique where you use an suture anchors. So is there a technique of a socket, making a socket and then pull through suture something as well?
Yes, I've read some 2-3 series when I was going through literature. They do use like a pull-out stitch, and then they have a endo button which can be tied from the top or outside the cortex. I had seen few articles which I've gone through. I don't remember. It was recently 2016 or 17. Sir.
Is there any comparative study, Ramakanth, between these two?
No, technique-based comparisons was not there, sir. Mainly repair versus reconstruction, or repair alone versus internal brace was there.
The literature, okay.
Yeah, Ranjit.
Ranjit.
Yeah, Ramakanth.
Yes, sir. Yes, sir.
Yeah, nice presentation.
Yes,
my question is not related to your case, but to repair as a whole.
Yes, sir.
We all know whenever ACL ruptures,
yes, sir,
it fails throughout the ligament. So just
yes,
by inducing healing at the top of the ligament, will it be by repair of ACL, will it be an enduring way of fixing the problem?
I really didn't get you the question, sir. Whether the repair
when the ACL ruptures, it
yes,
fails throughout the ligament, not
the
at
ligament.
the top.
Yes, sir.
Yeah. So by inducing healing by repair at the top,
yes, sir,
will it be an enduring way of fixing this problem?
That is why the case ligament selection is very important, sir. Actually, as I told, Sharman 1 and 2 will be the ideal case for a repair. Rather, and also the remaining sleeve of the bundle of ACL needs to be intact. So sometimes we do take up the patient for repair, and then we find it intra-articularly that there is a tear extending down. So we can always have the option of doing a reconstruction than doing a repair and then having a failure. So only type 1 and type 2 would be the ideal case for the repair, sir. And also, obviously, if there is a tibial sleeve off is there, it's like a tibial avulsion fracture that also can be repaired. But when there is a tear from the femoral attachment and then the tear extends down, so always better to go for a reconstruction rather than a repair, sir.
Dr. Ramakanth,
yeah, because the literature says,
yes,
except from the femoral avulsions, pure avulsions from the femur,
yes, sir,
other types, even type 2 also, yes, there is some effect on the entire ligament, not at the top. So if you are repairing just at the top, so that may be the cause of failure in ACL repair, number one. Number two, when you are using this fiber tape, so what is your take on the stress setting effect on the healing ACL fibers? Because this fiber tape in the long run, it will cause scar tissue formation and it will hinder the formation of the healing ACL fibers.
No,
So,
actually,
what is your take on using this fiber?
Yes, sir. Actually, when I gone through the literature, the use of fiber tape, theoretically, what they have mentioned is when we use the fiber tape along, it holds the clots better, so it helps in healing. That's what I was able to find out from some of the literature support from biomechanical study as well as from the other papers. So the advantages of fiber, one of the advantage of the fiber tape was it retains the clot better for the healing to happen, sir. And regarding the tightness, you should always, before fixing it, once it is in the anterior cortex, we take it to knee range of movement and then try to hold it and find out which is the best position. So it is between 30 to 50 is what we could find it. And also from the literature support, they have told that 30 to 50 would be the ideal, so that there is no too much tightening or there is no slackening effect in the fiber tape.
Dr. Ramakanth, I had a concern with the surgical technique.
Yes.
Now I saw that you have used two swivel lock anchors, and if I'm not wrong, you have used about 4.5 mm.
Yes.
Now I usually use one of that.
Okay.
Now using two of them with the bone bridge of about 2 millimeters between that, is almost you're like occupying a space of about 11 millimeters. Now I think, don't you think that this is like burning a bridge? In case the repair fails, your reconstruction would be a little difficult rather than using one knotless anchor. I mean,
actually, instead of taking when you're it all how you it is all how you take the bites in the bundles. So when you take the bundles superiorly, when you take the first suture superiorly, and then as for the AM bundle, and when you take the bundles in the inferiorly, so it is really far apart because you're going to put those two anchors in the original bundle location. So I found that there was no really problem or any bridge of bone breaking or anything, because it is the sutures were not taken along the complete thickness of the ACL stump.
No, not the bone bridge. You're burning a bridge in case if you want to do an ACL reconstruction in future date, if the ACL repair fails. Okay. Now leaving a void of 11 millimeters is big there with two swivel lock anchors. Yeah, probably I think one is a better idea.
Yeah.
Yes, sir.
What Ramakanth is mentioning, that we are taking two separate anchors and we have the two separate bundles, and we don't go as to exactly over the footprint. We try to put it over the top of AM bundle. We keep it in the top of that footprint so that the AM bundle sits over there. At the same time, in the posteromedial bundle, we put it just in anterior to the posteromedial bundle. So we don't occupy that footprint space with the anchor. So anchor is well apart from that footprint. So even if you want to do a reconstruction, it doesn't come on the way. So we don't come closer. Yes.
That's a good trick. Yes, sir. Thank you.
I think we are getting late, and
can we
is
have
there any online questions? Online questions?
Srinivas, for any questions for Srinivas? That's an excellent presentation, because he did a staged corrections doing ACL reconstruction, then did the deformity correction. It's an excellent presentation with a very good outcome. Any questions for Srinivas?
Very sorry, I had a few more slides, but the connection had been very unstable. I couldn't complete my presentation. Thank you.
It was fine, but you showed the end result of that case, so that was good. I think if there are no further questions, any Ramakanth?
Yes, sir.
Does it have any different rehabilitation protocol is the question on return to sports?
Yes, actually, with the ACL repair, we tend to go a little slow rather and compared to ACL reconstruction. Maybe partial movements we can start early, up to 2 to 3 weeks, and then toe touch walking and full weight bearing from 1 month, and full range of movements after 4 to 6 weeks. That would be this thing, and the return to sports would be definitely a little later. Later date, like maybe beyond 6 months or 7 months period.
Okay, one more question is what is the criteria on deciding the repair? I think already we discussed about it.
Yes, Sharman 1 and 2 would be the
and
choice.
also, I think people, I mean, the very young and active patients, the chance of failure is a bit higher. I think people, I think in that large series of cases, they advise less active patients. Is it true?
Yes, sir. Because younger patients tend to go back to routine activities early. So with the repair, we do find increased re-rupture rates after the repair.
The question to Srinivas.
Yes, sir.
Would it be better to correct the lower limb alignment first, followed then ACL reconstruction and meniscus repair? Any specific reason why ACL was done first? There was a question from Divya Priya.
She had a very painful knee, acute painful knee. And a bucket handle tear of the meniscus that had to be repaired. So after repair of the meniscus, I had to stabilize the knee because otherwise the repair would fail. So that is the reason I did ACL and meniscus first. And once she recovered from that, the rest of my presentation was actually explaining the rationale of this. Actually, unfortunately, we couldn't go through that. So the second stage was done to correct the deformity to prevent future problems.
Thank you.
So we thank IAS for making us moderators, and once again thanking each one of you for attending this meeting. And now Dr. Vikram. And then
so thanks Gopinath for co-hosting. Thanks Sundar, IPS, and whole EC team to giving us this opportunity. Thanks all the speakers, Dr. Arumugam, Ramakanth, and Dr. Srinivas. And Dr. Srinivas, indeed your presentation was very interesting, and there was some of the technical glitches, and that's why we want that all things settle down and someday we can have a physical meeting.
Yeah.
And I think we can conclude the session now.
Okay. Thank you, Vikram and Gopi, and all the speakers, and have a good night. Thank you.